Thank you very much, Ronnie, for this lovely introduction. And I'm very happy to host this webinar because the AlgoMed is actually one of my favorite devices from Medoc. And I really think that pressure algometry is an interesting modality and a very important one in pain research, but also in neurology. So what we're going to talk about today, we're going to talk about in general what pressure algometry is and why pressure algometry should be used. And then I'll go a little bit into why the AlgoMed and what I'm so happy about with the AlgoMed. I'll show we'll do a demonstration so you see the device in action and you'll see how it works and we'll talk about the parameters of the AlgoMed that you can adjust yourself and the software and the reports that you can put out. Later on, I want to talk to you on a very practical note on how to perform pressure algometry and some important tips for that. And then we'll talk about the different literature findings that were gathered with the AlgoMed. So let's start, won't we? So what is pressure algometry? Pressure algometry is a method to assess deep somatic pain through mechanical pressure stimulation. And the tissue that we're aiming at is the muscle, the fascia, which is the layer surrounding the muscle that is providing the muscle with the vasculature and nerves, and the tendon, and the periosteum, which is the layer surrounding the bone. The bone itself is not very sensitive to mechanical stimuli, but the periosteum is very much. So these are the different types of tissues that we are aiming at. And I put skin in between brackets because we cannot test the muscle without going through the skin. So the skin receptors also play a part when we do pressure algometry. And why pressure algometry should be used? First of all, because this is a good mechanistic pain stimulus specifically for patients with musculoskeletal pain. So if we are talking about juvenile idiopathic arthritis or an osteoarthritis or a neck pain or a low back pain or fibromyalgia or even sickle cell disease where the pain is perceived in the muscle tissue. So we want to have a stimulus that is perceived as close as possible to the pain that these patients are feeling. So this is one aspect. Another aspect, or another reason to use pressure algometry is to use it as a test stimulus for the condition pain modulation paradigm. And for those who are not very much familiar with condition pain modulation, CPM, and this is a measure of descending pain inhibition. So in CPM, when we do test CPM, we usually give a painful stimulus, for instance, pressure algometry. Then there is a pause. Then we introduce another painful stimulus to another remote body site, for instance, putting the foot in a cold bath, and then during that the foot is placed in the cold bath, or right after, we give the same exact stimulus that we gave before. So again, for instance, pressure algometry, and then we see the differences and we see how much inhibition there is in this patient. And if you would like to learn more about CPM and how CPM is performed and some research that has been published about this, I would very much like to invite you to watch our CPM webinar on our website in the recorded webinar section. So this is some more information that you can gather. And there has been a recommendation paper published in 2014 as a result of the consensus meeting that was held in EFIC in Florence in 2013 by pain researchers, leading pain researchers, and they recommended also, among others, the use of a mechanical stimulus and also having a descending stimulus, for instance, a limits test that is being stopped by the patient. So these are two recommendations that are applicable to the use of pressure algometry as a test stimulus for the CPM paradigm. Another option is to measure exercise-induced hypoalgesia. And exercise-induced hypoalgesia is a decrease in pain sensation following exercise, being it aerobic or anaerobic exercise. And usually, often pressure algometry is used, and it's used on the muscles that were at work, for instance, the quadriceps muscle, the big muscles that were at work during the exercise. So this is another measure that we often see in literature. And another important measure is the measure of central sensitization. For instance, if we have a patient with knee osteoarthritis and we do testing on the uh, joint line of that knee, and then we do testing on the trapeze muscle. And if we compare these patients to healthy controls, and we see that they have also lower thresholds at the trapeze side, we can say, okay, there is central sensitization going on. Their pain is not, or the lack of inhibition, the pain is not only limited to their knee. It's a widespread pain. So this is also an important measure for central sensitization. So there are many options to do pressure algometry and devices around on the market. And why am I so excited about the AlgoMed? The AlgoMed is a device that comes with a software package. So you have the device and you have the software that leads you along. First of all, the AlgoMed has a very good ergonomic grip, so you can hold it very easily. You don't have to fumble with a small, narrow surface. You can hold it easily in your hand, and this is a good way to apply pressure. It first the AlgoMed itself, there's nothing popping out of it. Okay, so it measures pressure, and it measures the pressure that you as an operator are exerting, and it measures also the pressure increase. So you know that you're giving a good, steady stimulus while you're applying the pressure. So it gives you a real-time visual feedback of the pressure and the pressure increase that you're applying. And not one of the minor points, but it has very good to excellent repeatability of what we see in literature, and I'll be happy to share some of those findings with you later on in this presentation. Of course, the AlgoMed is applicable to any body site. You can do it on small parts, for instance, the nail cuticle, but you can also do it on the lower back or on the shin, and this is different from other types of algometers where the finger has to be inserted and then it will be only applicable to the finger. And thanks to the patient response unit, it gives you a real time patient response. So as soon as the patient is pressing the button that their pressure pain threshold has been reached, then that pressure is noted in the software. So there is no delay in the pressure. Of course, you can also use the device without the response unit, and we have had customers that do research on quadriplegics, and they have this type of patient group has less control over the upper extremities, and in this case, the patient can verbally indicate that they have reached their pressure pain threshold, and then you can lift the device off of their body, and that pressure, the highest pressure that you reached, is also noted in the software. And last but not least, it computes automatically the results. So you have the results, and I'll show you it later on the screen, and those are automatically computed and averaged, and you have standard deviations for those, and then you have a good statistical measure of how well you did the test and how reliable these results are. Let's go and show you what the software looks like so you understand how the device works. I'll stop sharing my my presentation, and I'll go into the software, and I'll reshare this screen. Yes. Okay, so this is what the screen of the AlgoMed interface looks like, and we can select a patient, and you can have a long patient list. It really doesn't matter, but in this case, I had only one patient in the patient list, and now I'm selecting a program. As you can see, this is a limits program, so indeed, like with thermal stimuli, the pressure is ever increasing until the patient is stopping it for reaching the pressure pain threshold, and pressure pain threshold is the first moment that the pressure is found to be even the slightest painful. So let's do this test, the limits test for the pressure pain threshold. And since I'm going to do this on myself, I want a body set that I can reach. So let's take my left tenor eminence, and you can choose that body set, and it will also be noted in the results. And let's go to the test. So just to show you what we are looking at in this screen, we have this white line, and this is the line that we aim to follow. And later on, a pink line will show up, and the pink line is the actual pressure that I'm exerting. So we would like our pink line to follow the white line as closely as possible. The two green lines, those are the pressure tolerance lines, and those are a visual aid for me to stick as close as possible to the white line. Here below, we will see the results of trial 1, trial 2, trial 3, and trial 4 for every stimulus that we give. So let's start the test. You will see that it will start counting down, and in between tests, now we press the button, it starts counting down 5 seconds, and let's apply the pressure. And this is the pressure that I am exerting. So if I put more pressure, it would look like this, or less pressure, it looks like this. So you can see that it's very responsive to whatever I'm doing. Let's do it again. I want to show you that on my hand, you can see the impression of the tip of the device. And this is very normal, and this will pass in a few minutes, but you can use this in order to just be just next to it and not sensitize the exact same area. So let's do it again. And you can see that as soon as I lift the device off of my body, it notes the highest pressure that I reached. Let me just now use it with the response unit. And you will not hear the ring, but I will hear it in my headset. But you will see that as soon as I press the button, I hear a ding, and it stops the pressure. And you can see that I have now 2 rings on my fingers and on my thenar eminence. And this is the way I want it. I want it just next to each other, not the exact same spot. So I'm not sensitizing the exact same spot on the muscle. So this is after I did 4 different stimulations. And you can see below trial 1, trial 2, trial 3, trial 4. And you can see me messing around during trial 1. And you can also look visually on what the pressure looked like when I exerted it. Let's stop this share and go back to the presentation. Okay. So thus far we talked about what pressure algometry is, and we showed you what the AlgoMed does. And let's go into what the different parameters are that you can change in when you use the AlgoMed. So first of all, the units of measures. Most researchers I see use kilopascal, and this is also what I used thus far. But you can also choose kilogram force per square centimeter or pound force per square inch. So this is up to you to choose any of those 3 as your units of measurement. And the maximal pressure that you can exert, or that this device measures, is 2500 kilopascal. So that's quite a lot. I don't remember ever reaching a pressure pain threshold of 2500 kilopascal with anybody that I tested. A parameter of the device that you can change is the rate, for instance. So when I tested just now, it was a 35 kilopascal per second rate, but you can also do a higher rate, for instance, a 60 kilopascal per second. And you can see now that the slope is quite more steeper. And just to remind you that when you use 60 kilopascal per second, it's just a little bit harder to have to stay steady on this rate. And by the way, you can adjust the rate to be between 0.1 and 100 kilopascal per second. The DFNS, for instance, recommends to be at a rate of 50 kilopascal per second. So something to keep in mind. In most studies, I see a rate between 30 and 60 kilopascal per second. If you are testing a a big muscle, for instance, the quadriceps, and where I don't know, in athletes that are not very sensitive, you may expect that their pressure pain threshold is quite high. And often I see when people are testing on those body sites, they choose a higher rate because otherwise it takes forever to reach their pressure pain threshold. And we have to keep in mind that the receptors for mechanical stimuli have high adaptability. So if it takes you a very long time, maybe you'll never reach the pressure pain threshold. Another parameter that I'm often asked about is the pressure tolerance, and this is actually the two green lines and the distance between the two green lines. So in this case, it was like the default 50 kilopascal, but if you take it wider, it will be 100 kilopascal, and then you have a wider range around the white line. Again, this doesn't do really anything, but give you a visual cue and a motivator to stay on the white line. So keep this in mind. I like it narrow, but it's up to you to arrange it any way you like. Other parameters of the device that I think are important to talk about is the response unit audio feedback. And I always have it checked, and I really like it that I hear the ding as soon as the patient is pressing the button. And why do I like it? Because as soon as they press the button, I want to lift the device as fast as possible from their skin because I don't want to sensitize them. As soon as they press the button, they're already on their pressure pain threshold. So I want I don't want to be above that range. I want the device lifted off of the skin, and this helps me do this as fast as possible. Another parameter that you can change is the number of trials. So here we did 4 trials, but you can do more. You can do up to 100 trials per sequence. And if you guys are interested in doing 300, you could do 3 sequences of 100 trials, and that there's no problem with that. In most studies where people are looking into pressure pain thresholds, I see the use between 3 and 5 trials per body site. So keep this in mind. This is up to you to choose how many you want to do. Ignore first stimulus is a box that you can check, and it may be used as a familiarization tool. Ignore first stimulus will say that the device will or the software will ignore the results of the first trial in terms of its statistics. So it will not be calculated into the average of all the trials. So you can either use the ignore first stimulus in order to familiarize the patient with the stimulus, or you can say, I'm doing a familiarization round, and I always recommend doing a familiarization round with all stimuli that you're going to introduce. So you really, really lower the anxiety level, and you make your patient ready for what we're looking for when we're testing. And this is a time to ask questions and understand very well what responses are required from the patient. Okay. And the last one that I want to introduce to you is the ISI, the interstimulus interval. And this is the interval between two stimuli. So this is the countdown that we saw on the screen, that it says wait, and it started counting down from 5 to 0. And only at 0, it said start applying pressure. This is something to keep in mind. The ISI is that countdown. You can do an ISI of a minimum and a maximum ISI that is the same. So 5 seconds it will be. But if you do a minimum ISI of 2 seconds and a maximum ISI of 10 seconds, the computer will randomly take a number between those two numbers. So it could be 6, or it could be 8, or it could be 3, and that will be your ISI. In contrast to thermal stimuli, this stimulus doesn't start automatically. It only prompts you to start applying pressure. So you have to see it in this light. At the end, it is up to the operator to apply the pressure at the right time. If you start applying the pressure before the countdown is over, by the way, those results are not noted. So you'll have to wait for the countdown to end. Again, a parameter that you have to keep in mind and that you need to come to a decision about. So after we did the testing, we can have a report. And I think this is a great feature for you clinicians out there, because a report can also give you comprehensive information, but can also give you the ability to show your information, to share it with your patient. So this is the standard singles report, and you can see a graphical representation of the test scores, and you can see that those lines were quite nice and straight. And it will also show the average and the standard deviation of the peak pressure of all the trials together, and the average and the standard deviation of the rate of all the trials together, and the maximal and minimal peak pressure um, of the 4 trials that we did. Now, another report that I really like is the bilateral report. So if you have 2 of the same body sites, for instance, 2 tena eminences, and of the same patient, using the same program, then you can compare them, and you can choose those 2 tests and put them on the same report, and then you can see the delta between those 2 body sites. And for instance, if we're interested in CRPS, complex regional pain syndrome patients, this could be an interesting way to look at the results and to see the difference between the affected hand and the unaffected hand. Another possibility of a report could be a pre-post report. So this would be the same body site on the same side of the same patient with the same program, and we can do a before and after intervention. So in this case, for instance, we can test, uh, uh, smear some capsaicin on the tested body site, and then after a while do the test again, and then we can see the differences between the results. So we can see if there is sensitization now that we put capsaicin under. So it will show the average peak pressure and the delta between the before and after test. And another report, and this could be interesting if, for instance, you have a orthopedic patient or a fibromyalgia patient that you are starting a medicinal course with, and you want to test them over the course of several months, and you're testing the same body site over those several months with the same program, and you can use 2 or more results, and then you can see really the trend of how those results went over time with a time and date stamp on them. So thus far, we talked about what pressure algometry is. You got a small introduction on the AlgoMed and the software of the AlgoMed. And now I want to look with you about some practical considerations when you do pressure algometry testing with the AlgoMed. So some really common mistakes that I see when I teach people to use the AlgoMed is the first one is applying too much pressure. And often it's because people think that they have to pressurize it, but really when you start applying pressure, I really want you to only have the weight of the device in your hand, and that will already start the pink line from running, and then only you have to add pressure. So this is a common beginner's mistake, and of course the software shows you and teaches you to to be better over time. But this is a common mistake that I often see. Another mistake, and this could be a result of applying too much pressure, is overcompensation. So I applied too much pressure, and now I'm relieving the pressure, and the patient is totally confused about what's going on. It was more pressure, now it's less pressure. Are we getting there? And what I would do in the case that you're applying too much pressure, instead of relieving the pressure, stay at the same pressure until you meet the line, the white line, and then start following the line. So or redo the test. This is also a possibility. But there are options to do it otherwise and not overcompensate. And this is a classical mistake, losing power. This is when you're not well equipped to apply enough force to reach the pressure pain threshold of this subject. And this has much to do with your own position and patient positioning, and I'll get into that a little bit later to explain how to handle a situation where you have to apply force, and how you can keep up with the patient you're testing. So some golden tips. I want you to always have a visual of the tested body part. I want you to see the skin. I don't want you to do it through their shirt or through the pants. I want you to see the skin when you're doing this for several reasons. One reason is there may be a scar tissue below that shirt that you're not seeing, and then you're applying pressure to scar tissue. Scar tissue is differentially innervated. It could be less sensitive, it could be more sensitive, and if you are not interested in testing scar tissue, then you want to avoid that type of tissue. By the way, there has been an interesting study where they use the pressure, the AlgoMed, to test skin flap techniques and if of the donor side, and to see whether the healing of a specific skin surgical technique was better than another surgical technique. So in this case, they did want to look at scar tissue. Another thing that can happen is that your subject went to the beach yesterday and got a sunburn. You're not seeing this because they have a shirt on, but if they remove their shirt, you can see that the skin is sunburned. If the skin is burned, the skin will also be painful. And then what is it that we're measuring? Okay, because the skin will start hurting as soon as we are applying pressure to it, and maybe we should reschedule this person when we see a situation like this. So these are two reasons why you should always have a visual of the skin and the body part. Another thing is that I want you to keep in mind is bony convexity. The bones are often, they have sometimes flat surfaces, they have sometimes round surfaces, and if you start applying pressure on the round surface, you may slip off of it. As soon as you slip, this is very, very painful. This is very sharp pain that will stick around for a while. So I want you to keep in mind when you're choosing the body size that you're going to do, this is a site where you can apply pressure without slipping off of it. And on a personal note, I was a part of a study where we wanted to test the distal radial bone, and in our pilot study, we noticed that we're slipping off of it and we're hurting, and it doesn't work. So we decided to test on the intersection between the radial and the ulnar bone, and where there's a good musculature and it's a flat surface, and it was easier for us to do it without slipping off and without hurting the patient in a way that it's not controlled, and and not in a way that we test pressure pain threshold. Another thing that I want you to keep in mind is to be perpendicular to the body surface, not to the floor, to the body surface. For instance, if I'm going to test this my tena eminence right now, and it's supported by a surface. I want it always to be supported by a surface. If I'm going to be perpendicular to the floor, it would going to be like this. And then I don't know how much you can see it, but it will start pulling the skin. When you pull the skin, this is a sharp burning pain. It's not the deep somatic pain that we're looking for. So I want you to be perpendicular to the muscle surface like this. We're not perpendicular to the floor right now. We're perpendicular to the muscle surface. And this is an important one and a common mistake that I see. And I want you to hold the AlgoMed with two hands. We have a good grip, and this is wonderful. But if you want to apply good force, I want you to hold it with two hands. I'm holding it always like this. I'm avoiding the cable, and I'm applying force with two hands. And it's much easier to apply, especially when you go into the higher forces. If you're working with athletes, if you're not necessarily with pain patients, and you're going into the higher pressure pain thresholds, it will be hard to do this only with one hand. So I talked to you before that patient positioning is super important, and this was actually studied by Sharon Wang Price back in 2019, and she looked at uh, patients with symptomatic neck shoulder pain with intermittent pain and tenderness, and also asymptomatic individuals, and they did 4 trials per body site per position. So they tested the middle deltoid, the levatoscapulae, and the upper trapezius in a sitting and a prone, a lying down position on the face. And they actually found that when you're testing in a seated position, when there is tension on a muscle because of the weight of the arm being pulled by gravity, the pressure pain thresholds are lower. And this was both in the symptomatic groups and in the asymptomatic groups. So keep this in mind. Okay, so when you're doing your study, make sure that you can test all your patients in the same position. For instance, that you cannot have one patient sitting and the other one is lying down. It's not the same test, and it will give you uh, um, not clean results. Um, what they also tested, by the way, within a few days, and they found really between a good and excellent repeatability. The excellent repeatability was mostly in the symptomatic group, and in the asymptomatic group, there was between good and excellent repeatability. So this is another study showing that the AlgoMed has great repeatability. By the way, you can see that they are holding the AlgoMed with two hands, like I'm recommending you to do so. Some golden tips. So again, about patient positioning. As with all QST, I want the patient to be comfortable. Have a comfortable chair for the patient. Uh, I need a patient to be concentrated on the stimulus that you're giving them, and not on the fact that because they're not comfortable, their lower back is hurting, or their hip is hurting, or they're moving in their seat. I want them to be as comfortable as possible, because otherwise they cannot be concentrated on the lab stimulus that we're giving them. They are feeling something else uncomfortable in their body. I want you as an operator also to be comfortable, because if you are not comfortable, you will not be able to give a good, steady pressure increase rate. So I want you to be comfortable. I want you to be in a position where you are able to apply pressure and you are comfortable and you don't have to twist and turn, and because this will affect the quality of your test. Again, I want you to have good access to the body parts. And we talked about the previous study where you had patients lying down, you had patients sitting up. I want you to be able to reach that body part easily, and also use gravity, preferably use gravity. So I like you to use gravity to your advantage. This has much to do with the ability to apply force for you. And I'm putting it between brackets, but it should be in bold. I want you to stand up when you are applying pressure. I want you to stand up, hold the algometry with two hands, and then you can lean in. So as soon as you don't have enough force anymore coming out of your muscles, coming out of your shoulders, I want you to lean in and use your body weight to apply the correct pressure. So stand up, please, when you're doing it. Especially as I often see this, people are testing a patient. He's sitting down in front of me. They're testing their trapeze muscle, and they're also sitting down because it's comfortable and we're all tired, and they start applying pressure like this, and then at a certain point in time you don't have enough force anymore in your shoulders. If you would stand up, it would be easily done, and you can just lean in and apply more pressure to reach the pressure pain threshold of your patient. Another important part is that the body part of the patient should be supported, preferably by a steady surface like a table or like an examination bed. I don't very much like to see people holding a patient's hand, for instance, and applying pressure with their other hand. This is a messy situation that can go easily wrong, and that you will not be able to give a steady pressure over time. So I want you to have the hand supported on the table when you're applying the pressure. Not a minor point, but something that you have to keep in mind. I want you to have a visual of the computer screen, because the computer screen is giving us the feedback about how we are doing in applying a rate in a steady, the pressure in a steady rate and in a steady state. So you need to see the computer screen quite well when you're doing the testing. But I don't want the patient to see the computer screen, because if the patient sees the computer screen, they can be distracted. They will QA you. They will say, "Oh, this was messy. You didn't do this quite well," or they will, as all patients will try to be as consistent as possible. I want the patient to be concentrated only on the stimulus that you're applying, and not about anything else. They don't need to see the computer screen. You will need to arrange the room accordingly. So for instance, if we're going to test my shoulder, then you probably want to move the computer like this. So I will not be able to see the computer, but the person behind me testing my shoulder will. Okay, so keep this in mind when you're setting up your room and your testing space. Where is the computer? Where is the patient? How is the patient seated or lying down? What body position am I going to reach? And in which order am I going to do this? So you don't move the patient around too much. The patient has to lie down. The patient has to stand up. The patient has to sit down. Okay, keep the comfort of your patient in mind. Okay, so up to now, we talked about what pressure algometry is, what the AlgoMed does, and some golden tips about performing the test. And I want to share some literature examples what has been done with the AlgoMed over the years. So let's go over first the paradigms. I want you to go over the most common paradigms that we see when in literature, and then we'll talk also about body parts and the types of patients that have been tested with the algorithm. So pressure pain threshold, as I said, is the first moment that the pressure is becoming even the slightly painful. And that's the moment the patient is pressing the button. And this is, of course, a limits test, that you may know from thermal testing as well. Pressure pain tolerance is the moment that the patient can no longer withstand the stimulus. And that's the moment that you want to stop applying the pressure. And I want to also talk about using the pressure algometry as a test stimulus for the condition pain modulation. And often what I see is that people use the pressure pain threshold test as the test stimulus for condition pain modulation for CPM. And a very rare one, but it has happened as a tonic noxious pressure stimulus in a ramp and hold way. So those of you that are familiar with thermal testing, we know that there's a stimulus going up and staying at a certain intensity and then going down. So this is also an option, and I just want to show you. And all of these are options that you can use in our software, or and that you can adapt or change in the programs or make a new program as you wish. So to talk about the paradigm of pressure pain thresholds, this was a very nice study out of Italy where they tested patients with hand osteoarthritis, and they tested them on several body sites and they compared them to healthy controls. And the program parameters were not mentioned apart from doing each test on each body site for 3 times. And they tested on the pressure pain threshold on the anatomic snuff box. So you would expect people with hand osteoarthritis to be painful here, and also on the hamatan bone, but also on the C5, C6 facet joint, the radial, the medial, and the ulnar nerve in the forearm. And they found in patients that they had lower pressure pain thresholds over the radial and medial nerve. And this is, of course, an indication for central sensitization. By the way, they had visits 1 week apart, and so they had a test and retest between visits, and they found excellent repeatability for patients and between good and excellent repeatability for the control. So this is in line with the previous study that I showed you before. Another paradigm that has been used is pressure pain tolerance. And in this huge study, and this is the secondary analysis of the large TOMSO study, this is a population-based study of adolescents between 15 and 19 years old, and they compared within that population those that had chronic pain and those that did not have chronic pain. And they tested pressure pain threshold, pressure pain tolerance. They did heat pain threshold with one of our thermal devices, and heat pain tolerance also with one of our thermal devices, and cold pain tolerance with the cold pressure test. And they tested on the cuticle and the upper trapeze. And what they found was that there was no differences between the chronic pain and the no chronic pain on the cuticle, but there was a difference both in pressure pain threshold and pressure pain tolerance at the upper trapeze site. And they also found sex differences. So females were more sensitive than males, and those with chronic pain were also had lower pressure pain thresholds than those without chronic pain. And off of all the QST that they did on this group, pressure pain threshold and pressure pain tolerance was the only one to be significant significantly different between the chronic pain and the no chronic pain group. So just to give you an example of pressure pain threshold to be used as a testing risk for CPM, in this study, which was performed during the COVID epidemic and before excuse me, before uh, vaccinations were widely introduced. They tested, and all of their subjects were not vaccinated. They had controls that never had fallen ill with COVID, those that had symptomatic COVID, and those that had asymptomatic COVID. And they did pressure pain threshold test for the CPM on the arm and the leg with a rate of 30 kilopascal per second. And their conditioning stimulus for the CPM was a cold bath of 2 degrees. And they had 3 visits within 7 days. And what they found is they found no difference in baseline PPT between the groups. So this is interesting, just to show that between the groups, control, symptomatic, asymptomatic, no difference in PPT. But in CPM, they found that those with symptomatic COVID had impaired CPM as opposed to those with asymptomatic COVID and control under control. So this is a way to show and to measure the effect of COVID on our pain system. And this is an interesting finding. And by the way, the retest reliability for PPT between visits was again excellent. And this is quite a rare paradigm, but I wanted to show it to you anyway by Stout out of Gainesville, Florida. And they had and they did ramp and hold stimuli, both with pressure algometry and with thermal, with one of our thermal devices. And they wanted actually to see whether there is a difference between chronic fatigue syndrome patients and healthy controls after a vigorous hand grip exercises, because they believe that vigorous hand grip exercises would affect the fatigue pathways and also would have interactions with the pain pathways as well. And what they did were 3 stimuli of 10 seconds and with a slope of 6 seconds and a plateau at 200 kilopascal or 400 kilopascal, and they adjusted the increase rate accordingly. So when they went to 400 kilopascal, they had a rate of 67 kilopascal per second. And they had the patients and the controls verbally rate their pain at the end of each stimulus. And what they found was that there was no difference in the patients nor the controls between before exercise and after exercise. So no difference at all. But they did find a difference in ergosity, in how the pressure pain thresholds were, or how these patients rated pressure pain, and they found that the patients were much more sensitive to these pressure stimuli than the controls. They rated their pain much higher. That's the right side of the graph. So I gave you some examples of what type of paradigms I mostly see when I see pressure algometry research. And now I want to introduce to you what body sites have been used. So we see that a lot of the pressure algometry is done on the upper extremity, being it because they want to do the pressure algometry on the same site as the thermal stimuli, and often they do the thermal stimuli on the ventral forearm, so they want to do the pressure algometry on the ventral forearm as well. Or the upper extremity is used as a control site. For instance, if I want to test, as I said, knee osteoarthritis, and I want to have a control site remote from this place. And the neck shoulder testing sites are equally involved in that. And we can see indeed that most common is the upper extremity, but neck, shoulder, and lower extremity is also quite common. There's also quite some work being done on the face, and we see a lot of testing on the masseter muscle for temporal and mandibular disorder, or on the forehead for migraine patients, but also some intraoral work on the tongue for burning mouth syndrome, or on the teeth for dental applications. So you name it, it has been done. But this is just to give you an idea of what's most common and what has been done in the past. In terms of the types of patient groups or the subject groups that have been used, the size of the font of the letters indicates how often I found this in AlgoMed literature. And you see a lot of work has been done on older adults or on healthy volunteers, but also quite a lot on knee osteoarthritis and low back pain. And you can see also that some of the focus was on condition pain modulation, but also work has been done on HIV patients or juvenile fibromyalgia. So um, again, very wide way to look at pain and a modality to use in your pain research. Just want to show you a classic example of use of the AlgoMed, for instance, in knee osteoarthritis patients. And this is a study by Genicel Cruz Almeida out of Gainesville, Florida in 2013. And they had a very large group of 194 middle older age knee osteoarthritis patients, and they wanted to identify psychological profiles within those patients, and they compared them and put them in clusters according to the psychological profiles. And they also had QST findings where they looked at heat pain thresholds and tolerance, but also at pressure pain threshold and pressure pain thresholds at different sites. And they found that patients with high optimism and no low negative effect, this is cluster 1, happy-go-lucky patients showed the highest pressure pain thresholds at all sites, and especially if you compare them to cluster 4, and this is the patients with high somatic sensitivity and pain hypervigilance, and they showed the lowest pressure pain thresholds across all sites. So this is an interesting way to look at it, and an interesting way to see parallels between psychological profiles and QSC. A study that I want to introduce to you, and for a specific reason, is this study out of 2021 from Sao Paulo, Brazil, by the Araújo Victor, and they tested pressure pain thresholds on children and adolescents with and without intellectual disability, and they had 25 children per each group, as the youngest one was 5 years old. And I'm mentioning this because some of you may want to do some testing on a pediatric population with our AlgoMed, and they would probably have to come up with literature of what has been done in the past. So this is a subject group that has been used in the past, youngest child of 5 years old, and they did pressure pain threshold testing on the masseter on the temporal muscles on 3 different sites. By the way, they didn't find any differences between the 2 groups in terms of pressure pain thresholds, but something to keep in mind, especially if you have to deal with the institutional review board and get approval for your pediatric study. Of course, pressure algometry is only one modality, and you can see that often it has been used in combination with thermal stimulations, and each gives their own dimension and their own information. And we also have the TSA2 Air and the TSA2 and the QSense devices that Medoc has designed and produces, and they are also very much known for their good, repeatable stimuli and precise stimuli. So keep in mind that this is also something that you may want to combine with pressure algometry, yes or no, really depending on what it is that you're trying to research. I want you to be ready and keep us in the back of your head, because coming soon will be our VSA, the Vibratory Sensory Analyzer. It will be released somewhere this year, and keep us your half an eye or on our side, because we'll be happy to tell you as soon as this happens. I want to thank you very, very much for listening. And those that have questions, please put them in the Q&A panel. I'll be happy to answer any of the questions. And if you have any questions specific for me, please send us an email at info-medoc-web.com, and I'll be happy to answer any of your questions, or if you need the references or full text of the papers that I mentioned, I'll be happy to comply. I'll look at the Q&A and see if anybody has an interesting question to ask. And please, those that are logging off now, I will be very happy if you fill in the survey at the end of the of this lecture, because we will always try to be better than we were before. So let's see what has been asked in the Q&A. Okay, so there's the question about does the rate of ascent matter with PPT? And well, it may matter. As I said, first of all, for you operationally, if you do it at a very, very high rate, it will be hard for you to do this in a precise way. So it will be hard for you to have a steady rate. If you do a very, very low rate, you may not reach pressure pain threshold at all. Mostly I see use, as I said, between 30 and 60 kilopascal per second, and the DFNS is recommending doing 50 kilopascal per second. So really, I would say look at what has been done in the past, and in terms of the type of population that you want to study. And it's always easier to say, okay, I'm following the protocol as was published by so and so, also in terms of the IRB and also in terms of publishing yourself. So look at what has been done in the past, and maybe you want to follow a protocol that has been done in a group that you use a similar patient group. Are there any more questions? Okay, then I thank you very much for joining. If you have any follow-up questions, please write us, and thank you very much for being here with us. Goodbye.